Okay, so I'll start. I think we have people are still joining, but we have decent number already. So welcome everyone, and it's an honor to welcome Dr. Phil Starr, who is a professor of neurosurgery and Dolores Kickbread Endowed Chair in Neurosurgery at University of California in San Francisco. Dr. Starr is one of the leading neurosurgeons, one of the pioneering DBS surgeons, and I have actually a patient who you implanted, who still comes to me at the VA. He told me he got implanted in mid-90s. So all that we do, he has been doing since mid-90s, and it's an honor to welcome him. And without any delay, I will give stage to Dr. Starr.
Okay, great. Well, thank you very much. I guess I will go ahead then and share my screen. Okay, can you guys see my screen in the correct format?
Yes.
Okay, great. Well, thank you very much for this invitation. Delighted to be with your group. This talk will be focusing on data and work with Parkinson's disease patients, and I'll try to make it reasonably general and explain things, since not all of you are intimately familiar with Parkinson's. I'll be talking about what is my most, I think, interesting work in the last 3 years or so, chronic ambulatory invasive brain recordings, and we're using this in part to understand the physiology of specific motor signs in Parkinson's, including bradykinesia, and their also tendency to fluctuate, motor fluctuations, or the alternation patients undergo when they're on levodopa medications. They alternate between a bradykinetic state and a normal, or sometimes dyskinetic, excessive movement state. And so we're understanding the neural basis for these things from chronic human brain recording, which I'll talk about. This on the right is from our medical illustrator, Ken Probst, his artist conception of what we're doing. We have a big team, as you guys do. Big team is needed to support this kind of work, but for our work in the chronic ambulatory recording, this is sort of our core group of investigators. Roe Gilroan, who just finished his postdoctoral fellowship with me, did a fair amount of this work. I work closely with Simon Little, a wonderful movement disorders neurologist who joined our group. Jill Ostrom is head of our joint neurology, neurosurgery, neuromodulation clinic, and then of course other people too numerous to account for. So in terms of what motivates me to do the kind of work that I will tell you about is, we've had deep brain stimulation for a while now. I started the DBS program at UCSF and San Francisco VA in 1998. So if your patient was implanted in the mid-90s, it had to be before me, but maybe it was the late 90s, because we started there. And our first case was, I remember, June 1st, 1998. So I'll just illustrate Parkinson's patients and the effect of deep brain stimulation. This is a patient in her 50s who is a candidate for deep brain stimulation, Parkinson's disease, for about 10 years, fairly young onset. She's been asked to stand up and turn around. And you see the hallmark of Parkinson's is bradykinesia. She's very slow. And you can't quite see her steps, but you get the idea. Very short shuffling steps. She's been asked to turn around. So she is very slow off of medication. And then 6 months after her bilateral deep brain stimulators, and this was subthalamic nucleus stim, this is also off medication. So in both cases, no medications, and you can see the profound effect of neuromodulation of the basal ganglia. And one of my motivations is that, I first got into this field. There was a theory. This surgery was one of the few in neurosurgery introduced from a basic science lab. The work really of Malin DeLong, basic science, showing that lesioning of the subthalamic nucleus could improve Parkinsonian signs like bradykinesia, and that was translated by Aline Benabid, a neurosurgeon in Grenoble, France, who then took Malin's work and said, okay, well, let's reversibly inactivate the subthalamic nucleus with high-frequency electrical stimulation, do the same thing. That's what launched this procedure. But what I was getting into, it is becoming clearer that deep brain stimulation probably doesn't work by inactivating locally the neurons in the region. So we then had we were doing this very remarkable procedure and didn't really know anymore how it worked, and I really would like to understand better. First, what are the brain changes that lead to bradykinesia and other signs of Parkinson's disease? And what is the basis for these remarkable effects of DBS? And finally, another motivation is that this is kind of a best case scenario I've shown you, a young onset patient who really worked very well. For other patients who don't get this much benefit, or where it remains hard to tune the device to make them move well without excessive movement. And so we're trying to use brain signals to improve deep brain stimulation by making it adaptive, that is, respond automatically to changing brain needs based on brain signals. So I'm going to talk about the available devices that can do brain sensing. This is a really dynamic time in deep brain stimulation with new devices available to do sensing as well as stimulation. I'll show you some brain behavior correlations from a few hundred hours of recording done mostly at home while patients do their normal activities, recordings from the cortex and basal ganglia, and talk briefly about insights into mechanisms of therapeutic DBS and implications for training clinicians with all of these new findings in physiology. So for many years, deep brain stimulation clinically for movement disorders has been with us really since Benavid's work in the early 90s when that was published. But for most of that time, they've been one-way devices. So the pulse generator, typically implanted in the chest, sends an electrical signal out to an end target, like here is pictured the globus pallidus, one of our targets in Parkinson's. The newer devices are bidirectional, so they do the same thing with chronic stimulation that the old ones do, but they have a sensing component. And in this case, in our protocol, we do a lot of sensing from primary motor area with an electrocorticography electrode implanted directly on the brain surface. But you can also sense from the same array as you stimulate in as well. There is a history now over the last 10 years of use of these kinds of combined stim and sensing devices. The first one that was approved for a clinical indication in the United States is the RNS responsive neurostimulator device from NeuroPace. And this was approved only for use in epilepsy. And it's a little bit different from the devices that I'm going to show you. It's, for one thing, it's a cranial mounted device, which has advantages and disadvantages. It's mainly made for so-called paroxysmal disorders like epilepsy, because it's not designed to be on all the time. It's really designed to give very intermittent stimulation. And in fact, it does not do sensing during stimulation. It's a so-called half duplex device where it will, wait to sense a signal. When it gets a certain signal, it stops sensing, delivers a certain period of stimulation, and then stimulation is over and it'll go back to sensing. And that's actually a simpler thing to do than sensing continuously during stimulation. It also isn't really designed to do chronic recording for many hours at home, although people are trying to use it that way. So the main device that I'm going to talk about in this work today is an investigational device from Medtronic called Summit RC plus S. The RC means rechargeable, and the S stands for sensing. This was made available to a number of groups doing investigational protocols. The protocols are all physician-sponsored. It's not part of a Medtronic study, but you do contract with Medtronic, the company, to get the devices for free and provide them with any data that they want. But the funding for these studies has to come from one's own funding, in this case, mainly an NIH UH3 award plus an R01 grant. So this allows continuous stimulation during sensing if needed. Is really therefore the first sensing device that was designed for movement disorders, and that is disorders that really need continuous stimulation. Does sense during stim, and it can stream by radio telemetry out of the pulse generator chronic time series recordings for many hours. In fact, the limitation on continuous streaming is 30 hours about, because after that you would have to then recharge the rechargeable generator, but it could do 30 hours continuous streaming and then have a recharge and then go again. The typical sampling rates are 250 hertz. That's what we use at home, but it can go up to 1,000 hertz sampling rate and up to 4 channels. Our protocol has 1 on each side, so we get 8 channels of brain data. I want to mention, I won't really be showing work from this, but one of the reasons people are very interested in brain sensing is because now there is the first commercially available brain sensing device that you don't need an investigational protocol to use. It's the Percept from Medtronic. Now it's the generation sort of what they developed from their early investigational work with RC+S and other devices. Now this is exciting because it's commercially available, right? We put it in patients with Parkinson's and indeed other indications as well, and you can do sensing. It's less powerful than the RC+S. It's not designed, partly because it's a primary cell, you can run down the battery. It's not designed for long continuous recordings at home. You can do recordings of time series in clinic, or at home, you can have patients trigger recordings, which gives you a brief, like 30-second snapshot of time series recordings. You could do up to 10 minutes with some work for those recordings. But in terms of chronic continuous recording, you have to pre-specify a particular spectral power band of interest, such as the beta band is often done, to monitor that. It won't give you long continuous time series recordings, but nevertheless, this is being implanted now in literally thousands of patients. And there's a lot of people out there now with sensing devices. Just a summary of what's available and the advances in sensing. Started with, again, the RNS device. I made a table here of the characteristics of these devices. Some are FDA approved, like Percept and RNS. Others are just investigational. Some are rechargeable, RC+S, the rest are not. Some are enabled to use brain signals to feedback on the stimulation amplitude or other parameters to auto-adjust them. That's so-called adaptive or closed-loop stimulation. Percept is not yet enabled for that outside of a Medtronic-sponsored study. Some of these allow great mobility during streaming of data. Others, you kind of have to be tethered, sit in a chair, tethered to a device, a recording system for data streaming. One feature of RC+S that is both good and bad is the device allows investigators access to its application programming interface. So we can directly program the device, gives us great flexibility, but we also have to write software in C#. And I had to hire a computer programmer who could write the software for this device. So that was a little bit new as an academician to be doing that. So this whole field of brain sensing in Parkinson's really got its start a while ago, really 20 years ago, using not implanted brain sensors, but patients who had just been implanted, where you recorded either intraoperatively or a few days postoperatively with the brain lead attached to an extension literally hanging out of the head, right? And so that was the first, for many years, that was the only way we could record brain activity. And types of recordings are field potentials from these macro contexts as opposed to single units from microelectrodes. So if you take a brain lead in, say, the subthalamic nucleus, one of the main targets for Parkinson's disease, you just connect it to an amplifier and look at it, you'll see an approximately oscillatory signal. It's pretty small. Here is one of our bigger ones at 10 microvolts peak to peak. And this is about a 1-second recording. And you can even just see in the raw recording, it has an approximately a beta band dominant oscillation. Now, it was noticed years ago from these brief external recordings that if you gave a Parkinson's patient their levodopa, which made them move much better, just like DBS does, you'd have a profound change in the nature of this field potential signal. Here's an off levodopa and on levodopa recordings from a publication of Peter Brown's work of 2005. The time series and then the power spectrum of these. Off medication, there's a strong peak, sort of in this case, the low beta, like 13, 14 hertz range. On medications, though, that beta band peak essentially goes away, and you can get the gamma band oscillation here. And this is actually a narrow band gamma, not the broad band gamma that people talk about with cortical function. So this was a seminal observation that you can use field potentials as a potential assay for the motor state of patients. I think this group, I probably don't need to go into this, but for groups that aren't, physiologically oriented or engineering oriented, I usually explain what you measure, what is the field potential measure, because to people who are used to single unit activity, it can be a bit mysterious. And the reason we do so much work in field potential reporting is that it's a very sensitive measure of neuronal synchronization, right? So if this is a schematic where you have some theoretical, in this case, cortical pyramidal neurons, and they all have, each cell is as a transmembrane oscillation, with an active membrane, it oscillates. So if you have a bunch of cells in a vicinity that are oscillating with a similar frequency and phase, and then you have a big electrode that records the summed activity of a bunch of these, if they're all synchronized, you'll get a nice signal, a signal of a decent amplitude. Say the neurons in the vicinity of the electrode are at different frequencies or varying phase relationships, they will sum up to a very small signal. So right away, you can see how the LFP field potential, local field potential recording, is a sensitive measure of whether neurons in the vicinity are synchronized or not. And these provide this oscillatory activity of populations of neurons, give this powerful window into neural circuits. And I like to show this, this quote from Donald Hebb. So many people are used to thinking about the single, how single neurons work. And Ramon y Cajal, of course, started the concept of the single neuron as the unit of neural function. And Donald Hebb said, as many people know, neurons that fire together wire together. That's a well-known statement. In systems neuroscience with oscillations, there's almost a similar principle, which is that structures that oscillate together talk to one another. And that's an evolving theory in neuroscience, that if structures that are functionally connected, such as the basal ganglia and motor cortex, are oscillating at similar frequency and phase, they are communicating with each other. And if they're not oscillating in similar frequencies and phase, then they're functionally not in a state of communication. So with that background on how field potentials are so useful as measures of synchronization, and knowing that Parkinson's is a disorder that seems to be related to excessive brain synchronization, we started this study of chronic sensing in Parkinson's and adaptive DBS. We so far have 15 patients with Parkinson's and 3 with isolated dystonia implanted with bilateral RC+S devices. Each is attached to the therapeutic electrode, which is either subthalamic nucleus or basal ganglia in our studies. And each is also attached to a sensing electrode placed through the same surgical exposure that I use for DBS. The sensor is an ECOG, electrocorticography paddle, that's just placed through the burr hole posteriorly to cover primary motor area. And then we get these 8 channels of recording streaming via Bluetooth from this little communicator that itself uses RF telemetry to communicate with the pulse generator. Patients typically wear the small kind of iPhone-sized communicator in their pocket. That has to be within a meter, but then they can Bluetooth, up to, it's about 12 meters to an external computer. So patients will have this on when they're in their house. They just keep it in their, the room that they're spending the most time in. Or some of our patients will, just stick it in a little backpack and carry this around with them so they can be outside streaming data, all day doing whatever they're doing. This protocol involves intensive data streaming at home. We wanted to identify and confirm personalized physiological signatures of these motor signs, but do it in the real world, instead of previously where it was patients sitting in a chair in clinic or in the OR with a lead hanging out of their head, very artificial environment. And this is the first time we're able to look at these signals in the real world and also start to understand the mechanisms of deep brain stimulation. You can get a lot of data from this device. In the very first 5 of our subjects that were studied by Roe Gilroan and published in 2021, he collected over 4,000 hours of 8-channel data, and just, again, this initial data collection from an initial 5 set of patients. So that's quite a bit more than all the work published with these short recordings with externalized leads from before. And we did it both awake and asleep, and before starting chronic stimulation and after stim. Most of the data I'll show is actually before starting chronic stim, in the first month, that is, from implantation until we start chronic stimulation. So this is, I'm going to show you probably the most important slide. If you need to just wake up for one slide, this is the good one to do, because I'm going to show you this brain behavior correlation. It shows the physiology of motor fluctuations in action. So what you're going to see is this is one of our early patients with Parkinson's who had very strong fluctuations. So he would be in a very off state, that is unable to move, like the woman I showed you in the first video. Then he'd take his Parkinson's medications and pretty rapidly, a few minutes later, kick into first, well, not quite a normal movement state, but a state where he can get up and move and walk around, but rapidly becomes dyskinetic, has excessive involuntary movements. And so you'll see the video of him transitioning from rigid and akinetic to now dyskinetic. And you'll see simultaneously a spectrogram of his primary motor cortex field potential recordings composed in frequency versus time, and the subthalamic field potential. And these are just where the electrodes are located. The cortical strip is spanning the central sulcus here. And here are the two subthalamic nucleus electrodes. This is the CT artifact from a CT scan superimposed on the preoperative MR, and there's the subthalamic nucleus. So even before I start, you can see what's going on when before his medications have acted. He's sitting bradykinetic, and he has this very strong 20 hertz beta band oscillatory activity in the subthalamic nucleus. Also has motor cortex beta, as expected, is a normal feature, canonical feature of the motor system. So you will see him shortly transition. He took his medications a few minutes ago, and he's suddenly going to transition from being rigid and akinetic to being dyskinetic. And you'll see a big change in the spectrograms right at the time it happens. So you see the beta go away, and watch his dyskinesias are starting. These are all involuntary movements. And look in the cortex, now you have the onset of this very strong narrow band 80 hertz gamma activity. It's strongly associated in him with the dyskinetic state. So it's a very nice brain behavior correlation in both subthalamic nucleus and cortex, showing the changes in so-called antikinetic brain rhythms, the beta rhythm, and the prokinetic rhythm of a gamma oscillation interacting. And it illustrates how the balance of those things are important for normal movement, and it's hard in Parkinson's to get that right. So that patient, I showed you a brief clip. It was the day after surgery, actually. But here's a sample from the same patient, 6-hour interval, just taken from his home recordings, showing that with him, going about his day, taking his standard medications, not being withheld, but just taking them when he takes them, you see exactly the same pattern, that he flips every several hours from the off state with this 20 hertz oscillation in the STN to an on state with the 80 hertz oscillation in the motor cortex. And then what we've done with the home recordings is, there's no neurologist there scoring patients as to whether they're on or off. So we have to have some objective monitor to give us the ground truth for the motor state, how they're moving, are they bradykinetic, dyskinetic, tremulous, et cetera, so that those can be paired with the neural recordings and decode their motor signs. So we've been using several different wearables. We have these early patients were using the PKG watch from Global Kinetics, which has a proprietary algorithm, essentially using triaxial accelerometry to give you scores of different Parkinsonian signs. So in this patient, you get over this 6 hours or so of recording, you get a score for bradykinesia going up and down, you get a score for dyskinesia, and you can actually see these are roughly anti-correlated. When his bradykinesia score is very low, his dyskinesia score is high, and he's moving too much. And we use the wearable then to classify them into on and off states, essentially, effectively. Medicated mobile states, where they're too mobile and dyskinetic, in his case, or immobile states. So then we can take, in this case, we took about 30 hours of home recording just during his daily activities, and we segregated those home recordings by whether the wearable said they were in an on state and moving, or an off state and not moving well. And we then did power spectra, averaged over, again, many hours of data. And when the wearable said that he was in an off state, again, you see in the subthalamic nucleus this beta activity. The scale is down here, that's about 20 hertz. And when he's in an on state, the beta goes away in the motor cortex. You have the gamma oscillation. A fascinating thing too is we can look at coherent activity between basal ganglia and cortex, which is probably important, again, in functional connectivity between these structures. And you see similar things in the off state. He has beta coherence. In the on state, the beta coherence is less, but he has this strong gamma coherence for this gamma oscillation. So what does this mean? You know, when we wrote the manuscript on this, one of our reviewers said, well, this really isn't important because these sort of things have been shown before. Although the gamma oscillation had really only been shown in the subthalamic nucleus, not in the motor cortex. So we had to argue, like, why is this important? So not only is this evidence for something that's been widely discussed, the oscillation model of movement disorders pathophysiology, but part of the importance is that the prior work had these electrophysiological signatures in highly controlled experiments right after surgery in the hospital, short durations. And now we can look at these, with patients going about their normal activities, in this case, cooking in the kitchen, recording 8 channels of brain recording. And then finally, I won't really go into this today because it's a little bit detailed in Parkinson's, but by pairing these long chronic recordings with the monitors of motor state, we can hone in on more subtle electrophysiologic signatures of motor fluctuations. And it's not just beta and gamma, there's an entire library of oscillatory activities, coherent activity that can help you predict the motor state of the patient. And you can only do that when you have a lot of data. One other thing that Roe did in this work is we were asking the question, okay, suppose you had a lot of brain recordings, but didn't have any ground truth as to what was going on with the patient clinically. Suppose you didn't have the monitor to segregate their data into specific on and off states. So we can also use so-called unsupervised clustering, where you just take 10-minute power spectra, all superimposed. This is again from many hours of data, and use a one of a number of unsupervised mathematical clustering algorithms to ask if the data tend to fall into specific groups that might reflect different brain states. That was easy to do in several of these patients in this study, where the clustering algorithm just pulled out 2 different families of power spectra that clearly correspond to on and off states, with the strong beta in the STN and the strong gamma in the cortex. So this may be applicable to when we're using these sorts of devices in patients, say with psychiatric disorders, where it's harder to have an objective monitor of what's going on with the patient. They still will cycle over days and weeks and months between severe symptoms, less severe symptoms. And you could potentially use these kinds of clustering algorithms to pull out brain states, even without a kind of an objective ground truth monitor. So we're then moving on from just recording physiology and understanding the neurophysiology. We wanted to see if we can use these brain signals to auto-control the stimulation amplitude. And that's the point of my UH3 Brain Initiative grant. And it actually has turned out to be a more difficult problem than I thought it was going to be. It's most of you would appreciate. It's actually a complicated problem in feedback control systems to do this. But this shows kind of a best case scenario, which is rare, of course, in our patients. So what we did is we had a patient. This was a patient who, after DBS, she reduced her Parkinson's medications, but she still needed it for some of her symptoms and for her mood, for her non-motor symptoms as well. But when she took her Parkinson's medications, she had to manually just turn her DBS off. And then when her medicines wore off, she'd turn it back up to around 1.3 milliamps. So we set her to do this automatically. And we used as the neural control signal her subthalamic beta, and this is shown over about 8 hours of recording, 3 cycles in her day when she has elevated beta, showing that she's in an off state and needs stim, or reduced beta, showing that she's in an on state, moving well, doesn't really need stimulation. And then set her stimulation current, shown in green here, to be triggered by a signal derived from her subthalamic beta, appropriately averaged with specific thresholds for making changes in stim amplitude. And we used a 2 threshold control here. And you can see that when she doesn't need stim and her beta is low, her stim is off, and then it automatically kicks in when she needs it based on brain signals. So this essentially did automatically what she was, self-aware enough to do on her own. Of course, a number of our patients won't have the wherewithal to just tune themselves exactly throughout the day. And so this is a way for those patients to have it happen automatically and meet their changing brain needs. And we've so far only published some short-term studies with adaptive stim. We do have another case from this same paper, where we use not the subthalamic beta, but we use motor cortex gamma, and exactly the patient I showed you in the videotape who would tend to get dyskinetic. And we used here in blue is now his motor cortex gamma signal averaged, and we've set in red lines neural thresholds that will determine, the crossings of which will determine changes in his stimulation amplitude. So when the cortical gamma goes up, means he's getting dyskinetic, and stimulation not only is not needed, but will exacerbate the dyskinesias, right? We'll have stimulation-induced dyskinesia. So that triggers a quick decrease in stim, for example, here. And then here is also a period where there's a bout of dyskinesias later in the day, and the stimulation is sort of automatically adjusted on a pretty fast time scale. The zoomed in view of this is here. And he did with both his subjective measures and his wearable monitor, did have a subtle but measurable improvement in adaptive stim. This was over 4 days at home doing this. And this patient has now been running in this algorithm for a few months, and we're still optimizing it before we collect kind of definitive data on it. One issue in general with adaptive stim, this is going to be true in Parkinson's and depression and all sorts of disorders where you use brain signals to adjust amplitude. What happens in sleep? Sleep strongly affects these neural signatures. So just as an example, in the subthalamic nucleus, again, showing you strong beta signal in the off state, gamma in the on state, especially in the cortex, all those go away when he's asleep. So what happens? What will the control algorithm do when they're asleep? It may give them the wrong stimulation. It's just not really appropriate to have the same control algorithm in sleep as it is awake. So Roe has another paper just out on sleep-aware adaptive DBS, where you use low-frequency cortical signals indicating the asleep state to essentially turn off adaptive and just go to standard chronic stimulation at night. So you don't have to worry about the device going haywire at night. So mostly the last thing I'm going to talk about is a little more on adaptive stimulation. There's a lot of challenges in developing adaptive stim. There's enormous interest in it right now, especially with the Percept device coming out and being able to do this pretty soon commercially. But it is challenging. The parameter space for designing the feedback algorithm is really large. All sorts of things you guys are familiar with from working on control systems in biomedical engineering. The details of how you average the signal, of the ramp rates for ramping up the amplitude in response to a control signal, where exactly you set neural thresholds for crossing. There are many parameters, and it took that first patient, we got this working, about 40 different iterations of a lot of trial and error, and that particular patient would tolerate it. He was sort of one of those people who do anything and happy to do it, but it was, very impractical to generalize that approach. Vastly more complex than the paradigm of cardiac pacers detecting and aborting heart rhythms. So we've been working in our UH3 grant on trying to solve this problem of this huge parameter space, and how do you do a principled way of setting the various control features in these embedded devices. And when we started, we had a very naive idea how this was going to work, which is we thought, okay, we'll just do the data I showed you a few minutes ago. We'll understand how brain signals change with the patient's motor fluctuations, as I showed you with all the beta and gamma rhythms. And then we'll work with the signals that best distinguish the on and off states, and we'll empirically set up an adaptive control algorithm that uses these signals to increase or decrease stimulation amplitude. And we thought that would be a little bit easier because these signals are clear, but the problem is that stimulation itself alters these signals a lot, and that makes it a much harder problem. So we have to consider not how these neural signatures, which I call biomarkers, even though it means different things to different people, but they're really we have to consider how these neurophysiological markers behave, not in patients off stimulation, but how they behave in the relevant stimulation range they're going to use in adaptive stim, and that's a completely different situation. So this just shows a little bit of our new approach, our principled approach to setting parameters for adaptive stimulation, which is we will take the patient, and they've been on actually chronic stim for a little while, so they know what stimulation is like. We know how well they can do with chronic open loop, that is one set amplitude all the time. And then we help them identify upper and lower stim amplitudes that are their optimal for different medication states. And it might be, for example, 1.5 milliamps when you're more in an on state, and 2.5 when you're more in an off state. Then we do their neural streaming from their device in 4 states. So on, off medication, on, off stimulation. And we look for combinations of neural signatures, not just one, but perhaps multiple frequency bands that distinguish their medication state and therefore their stimulation needs, and can do so irrespective of the actual amplitude of stimulation. So this is a theoretical case, for example, where if we find, and we had one patient, for example, where it turned out it wasn't beta, but it was the theta alpha subthalamic signal, where we could look at, in these theoretical violin plots, a distribution of that spectral power and find out that this particular frequency could tell us if he was in an off state or an on state, independent of stimulation amplitude. And then we can use that as a control signal and intelligently set up his control algorithm. And we're now using combinations of frequencies instead of single frequency to do this control. And I'll skip that. That just illustrates what I was talking about from the schematic. We're also doing a lot of work in what's often called fast adaptive DBS. What I showed you already was making relatively slow changes in stimulation, that is minutes to hours, that reflect these minute to hour fluctuations in a patient's clinical state. You adjust the stim accordingly. There's a whole other paradigm for adaptive stimulation, which has been looked at just so far with externalized brain leads, with a patient sitting in a chair for 30 minutes in the hospital. And that is doing much faster switches of stim on and off to trim these so-called pathological beta bursts, which is an evolving theory of bradykinesia and Parkinson's, that not just excessive beta, but it's actually excessively prolonged bursts of beta activity, as in this filtered time series reporting from a paper by Tinkhauser. The idea is when the device senses a burst has gone on too long, and the normal burst might be 300 milliseconds, the long one is 600 milliseconds, you deliver a very short pulse of stimulation, suppress the burst, and it goes off. So we've been developing this in parallel, and this is at the limit, technological limit of these devices due to, as you guys can imagine, a lot of ramp artifacts. When you ramp off quickly, you get a broadband artifact that will bleed through and affect the control algorithm. Finally, a couple comments, then I'll leave time for questions. You could talk a long time about using these devices to understand mechanisms of stimulation, but just one fascinating finding that we have found, but a little bit surprising, is that one thing that DBS does quite well is it entrains gamma rhythms. So stimulation is usually set around 130 to 150 hertz. We've never really known exactly why that's the magic frequency. But if you set it to that level and you look at power spectra, these are superimposed power spectra, about 10 minutes each over many hours from the motor cortex, with DBS off in red, DBS on in green. Now in red, before they started stimulation, they would occasionally, in these little red bumps, have those gamma oscillations, those prokinetic oscillations. But when they're on chronic stim, those prokinetic oscillations are now made a little more narrowband, shifted in frequency to half stimulation amplitude. When we first saw this, we were sure it was an artifact, just a subharmonic of stim, of the half stim frequency. But through a lot of experiments, we've shown it was not, in most cases, artifactual, because this gamma entrainment is highly sensitive to brain state. It's sensitive to dopamine levels, it's sensitive to patient movement, and that would not be true of an artifact. So we've seen this we've seen it with both subthalamic stimulation, this gamma entrainment on DBS, and with palatal stimulation. So it's a mechanism common, or it's a phenomenon, I should say, common to the two main targets in Parkinson's. And so we think perhaps this is important in the mechanism of DBS, but we're pretty early in investigating that. And finally, this work has implications for training. When I talk to more groups of neurologists, this is something that interests the neurology fellows about how the new electrophysiologic landscape of movement disorders is altering, fellowship training. For many years, fellows in neurology, fellows in epilepsy have had to be steeped in electrophysiology. It's the prototypic electrophysiologic disorder. But now these new chronic brain recording tools are transforming these other disorders like Parkinson's into electrophysiologic disorders, where we can now track severity of motor signs with electrophysiology. And so that really implies a new kind of training. We're really trying to beef up our own fellowships in movement disorders neurology to reflect that. The Percept is out, that commercially available brain sensor. It has a nice interface on the programmer where you can your patient comes to clinic, they're in a particular motor state, and you wirelessly from their device get a power spectrum and ask, okay, what's going on? How's their beta activity? How's their gamma, et cetera? So in summary, I've talked about this new generation of bidirectional neural interfaces that do sensing and stimulation, showed you some of the physiological correlates of motor fluctuations in the antikinetic beta band and the prokinetic gamma band from both basal ganglia and cortex. Talked briefly about possible DBS mechanisms and then implications for training. And I will stop there. And I guess it looks like we should have time for questions.
Well, I have a question, Phil.
Sure.
You were talking about the adaptive stimulation.
Mm-hmm.
And it seemed like that was sort of hand-tuned, would be one way to say that. Is that true?
You're saying, so tuned by hand is kind of what you're saying?
Yes.
Exactly. It was, this, we had to do lots of trial and error, changing thresholds and guessing, and then doing recordings and asking if the algorithm were working appropriately. So that's very much the case.
It would seem like this kind of screams out for some machine learning or some kind of automatic in the background approach.
No, that's exactly right. And in fact, if I go back a few, I have a neurology movement disorders fellow who's also as a PhD engineer and physiologist, and she's doing exactly that. She's doing machine learning approaches from certain data sets where you again do this neural streaming in multiple on-off med states, on-off stim states, using a machine learning approach to pull out promising control signals and set thresholds for that. And as you can imagine, once you set such a control policy, it might be good for a day or two, it might be different the next week, right? So eventually these devices are going to have to be really sophisticated and not only do, auto-adjusting stim, but actually auto-adjust the control policy too. And that will, Greg Worrell's group with our C+S at Mayo is actually doing that in epilepsy paradigm with the same device. And that of course has a lot of regulatory implications, right? Having a device in your brain that has that level of control to alter brain activity, but that's what will be needed.
It might not be quite as simple as I might have implied. I mean, you enter completely different states with just, not giant changes in the parameters, right? So, yeah, obviously constraints and things would have to be imposed.
Right. Let's see. I do see, I just noticed a hand up from Dominique.
Yes, thank you very much. Very nice presentation. I have a question about this gamma wave you're talking about, this
Yep.
induced power. plastic changes or stable? In other words, if you keep stimulating, do you keep seeing the same amplitude, or does it go away?
Very interesting. Again, this is just a little tidbit. The answer is it's not a very stationary phenomenon. We've seen patients who initially, when we first started STIM, had none of their own native gamma oscillations. They didn't have this behavior in red, but they would have good entrainment. And we've seen the opposite. We've seen patients who have a lot of native gamma and their entrainment is not very much. And it has been this interesting change over time, and we honestly don't know what to make of it.
So as a control, do you see that induced gamma wave in epilepsy patients who are undergoing DBS?
See, your voice is a little bit soft. I think you said you were asking about entrainment in epilepsy patients?
Yeah, as a control. Like, is this specifically to Parkinson's patients?
So, well, we actually we've implanted these devices in dystonia patients, a movement disorder with some overlap physiologically with Parkinson's. We also see gamma entrainment from both of these targets, subthalamic and pallidum. So this is a phenomenon of DBS in dystonia. Gamma oscillations have been seen, just natural gamma, not stimulation entrained, but just gamma oscillations in these narrow bands have been seen in the thalamus, not just in movement disorders, but in epilepsy patients and others who've had invasive reportings. There are a number of cortical areas outside the motor system, like especially the visual system, that has gamma oscillations, right? This is a physiological motif in a number of brain systems, but it really has not been seen outside of movement disorders in motor cortex. From all the epilepsy monitoring unit recordings that we've been able to look at, right? We really have not seen this kind of gamma oscillation. Of course, regarding the entrainment phenomenon, we don't really know, because the epilepsy patients in an epilepsy monitoring unit don't typically have, electrodes in the basal ganglia that you can test for entrainment, but I would love to know. And so, in general, our idea is that none of these brain rhythms are sort of invented by DBS or by Parkinson's. These are normal physiological motifs in various parts of the brain that are then hijacked in disease states and also manipulated by electrical stimulation. Looks like Carl, I see a hand up.
Hi, thank you so much. I think you've partially addressed my question. To follow up on Dominique's, if the artifact is created by the stimulus, that has to be stereotyped and predictable. So that's one advantage. So therefore, you can go back and literally filter it out from the signal. Was that done, or do you have plans to do this in real time?
So you're talking about the entrained activity or
the stimulus triggered artifact, precisely.
So this phenomenon that I'm showing here, we do not believe is artifactual. We believe it is actual entrainment of a brain rhythm induced by DBS, but not, if I understand you, an electrical artifact of the stimulus itself. We thought it was an electrical artifact, and this one doesn't really show it very well, but we have cases where the entrainment actually gets bigger or less with medication cycles, gets bigger or less when the patient moves and doesn't move. And those things would not happen with a volume conduction of an electrical artifact, right? So this entrainment is highly sensitive to the physiologic state of the brain, which I can't imagine how just an electrical volume conducted artifact would do that. Also, it's much larger in the motor cortex, very distant from the stimulation site compared to the basal ganglia electrode itself. So the electrode's just right next to it. It's not prominent typically. So that's another thing which goes against electrical art. Why would it be bigger 6 centimeters away compared to 2 millimeters?
And for the coherence analysis, was it directional or bidirectional?
We really haven't looked into that yet, but we are starting to. Mandy, another hand up?
Yeah, just a follow-up question on this gamma entrainment. I thought I heard you say that you see this with the high frequency stimulation at 130 hertz. And just wondering, what happens when you stimulate at lower rates at like 60 hertz or
Yeah, so I now have a graduate student, Maria Oleru, who is doing these stim titrations, where she'll sweep across different frequencies and amplitudes and map out when entrainment occurs, and is actually modeling, along with a group we're working with, the computational folks in Oxford, England. We're modeling these entrainment phenomenon within the framework from really physics of the behavior of coupled oscillators, right? One oscillator being the DBS, the other oscillator being brain networks. So she's been doing that frequency sweep. And I'll just say for now that below 100, the most prominent entrainment is the 1 to 2 entrainment, where frequency is between 130 and 180 hertz seem to entrain very well, 60 to 90 hertz oscillations. We haven't seen entrainment outside those frequency ranges. And interestingly, as you go to high amplitudes, you can lose entrainment. And that is predicted by this coupled oscillator theoretical framework, the so-called Arnold tongues, which is something used to predict entrainment between coupled oscillators. So the short answer to your question is, we've only seen entrainment with stimulation between about 130 and 180, and half of that, the 65 to 90, does correspond to the typical natural frequency of these gamma oscillations in the absence of stim. So, the network appears to be resonant at those areas, and if you're stimulating with a half stim amplitude near there, you will shift, as you see here, you've shifted the native gamma, peak about here, into the entrained gamma a little bit, but you can't shift it lower than 60 or higher than about 90 hertz.
That's really interesting. Yeah, thank you.
Thanks. Yeah, I love to talk to people about this, because this entrainment phenomenon we found is ubiquitous. We see in almost all the patients somewhere. It's variable. We have no idea if it's actually a mechanism of how stimulation is working, promoting this gamma prokinetic rhythm. Is it not that at all? Is it simply reflecting some resonance property of the neural network? We just don't know, and we're trying to figure it out. Let's see, who's next?
There is a clinical question. It looks like somebody's asking, how well does it do at preventing the clinical side effects, and how long does it take to titrate the boundaries?
So I think you're talking about setting up adaptive stimulation. How well
That's
does
correct.
it do?
That's what he meant.
Clinically. So far, again, these are early days, and the benefits are subtle. Partly they're subtle because I have a group of DBS neurologists who are experts at optimizing standard DBS, adjusting patients' medications, assessing them very carefully, experts at getting them optimized on standard, always-on open-loop stim. We certainly have some patients who are doing so well on standard stimulation, you couldn't hope to demonstrate better, essentially. Those tend to be the milder patients. For the more severe ones, just as an example, I had a little brief outcome. This patient who was on the cortical gamma controller, for example, his benefit, it's hard to measure in rating scales, but every morning when he gets up, he's pretty rigid and bradykinetic. He was on his standard, 2.8 milliamps. But if he had it set higher, then in the afternoons, he'd be really disconnected. So by putting him on adaptive, where in the morning his stimulator knew to be higher, and in the afternoon it knew to be lower, the effect on him is that he's less bradykinetic in the morning, can get moving better. That's his benefit. The showing effects on overall quality of life are challenging to do, because these are subtle benefits. And honestly, one of our big interests in setting up adaptive stim in Parkinson's, it's not that it's going to be some home run game changer for the effectiveness of DBS and Parkinson's, but I do feel like we and others are working out some general principles of using feedback control in these brain devices that will be applicable in other conditions like chronic pain that I have a colleague working on, or psychiatric conditions where adaptive stim may be more fundamentally needed for therapeutic benefit. Let's see, David, you had a question. Hi, David.
Hello, Phil. Yeah, I'm now with the Cleveland Clinic.
Great. I think I met you in Minnesota. Is that right?
Right. Yeah.
Yes. Yeah, in Jerry's group. Yep.
Yeah, I joined recently. So I have a question related to slide 28. You can go to the fast closed loop DBS.
Yeah, the fast adaptive.
Yeah. So I had some experience with the RC plus S and with our own externalized experiments. And one of the issues that I see is that the artifact of the high frequency stimulation, when you switch on or off, you have like a charging artifact that seems like a capacitive artifact.
Yep.
And that artifact takes a while to settle, right? And that can be, I don't know, it depends on the patient, the tissue, but it can be 200 milliseconds, it can be half of a second, okay? So the issue is that the envelope of the beta band oscillations changes faster than the artifact.
Yes.
So basically, I think there is some constraints in implementing this effectively, or feasibility of implementing the fast closed loop, because your controller is going to be slower than the dynamics you try to control or the observer you have. So therefore, it's a feasibility issue with this device at least, or with the leads. So have you, I don't know, has anybody in your team or people that you know try to?
Well, that was a very correct and eloquent discussion of exactly the problem, that the biggest problem with setting up these fast adaptive algorithms. The settling of it's not so much that a steady state stim artifact you can deal with. It's the transient ramp artifacts from these sudden stim changes that settle with a longer time course. You're exactly right. I was actually feeling kind of hopeless about this for a while with RC plus S. We thought that this kind of burst trimming was going to be just beyond the capability of the device. And of course, as you probably know, the Medtronic ADAPT trial, that's a Medtronic sponsored trial with Percept. They're trying to do fast adaptive too. And I was pessimistic. That being said, we have a paper just submitted to Journal of Neural Engineering from Juan Anso, one of our engineers who worked on this for a couple of years. And we have gotten some strategies that appear to be getting this to work. And now one of the key things is going from 0 milliamps, like Tinkhauser did, 0, all the way up to 2 or 3 milliamps to trim that ramp artifact is just too big to handle. But if you go from say 2 to 3 milliamps, like you have a baseline stim where the burst trimming won't even kick in at all until they're really in an off state. That's one breakthrough. And then they've also set the FFT length within the adaptive setup. And I can't tell you how Juan figured this out or why it works, but the FFT length can be set to be shorter, and that also helps to mitigate the transient. And of course, there's the sense blanking features that you can use. And if you put all these things together, we're just at the point where in one patient, we've actually done this. We're a long way from from showing it helped them, right? But technically, we've just, with a ton of work, done this. And one other thing, I know we're probably out of time, but this has a lot of implications for device design, because that capacitative coupling, you could design a device that didn't have nearly as much ramp artifact. Then you might be susceptible to certain hazards related to charge imbalance, though, from STIM. So this is a complicated area of device design. Do you really want to design it to do fast adaptive and accept certain risks or not? But thank you for your question.
One last comment, probably also to consider there, because when you ramp, the issue is that now your actuator, which is the stimulation, introduces a delay, and the delay is longer than is lower than the dynamics that you try to control. So we will move the problem to the actuation. Right?
Yeah, the delays are worse if you do distributed adaptive stim. So if you're doing it by an external computer, I don't know that with the embedded, I don't think that the delay was as fundamental a problem as some of the other ones.
No, that's not what I meant. What I meant is that when you do the ramping, you effectively add a delay, because at certain point the stimulation is not having any effect. Your ramp, your ramp starts having an effect on the brain at some amplitude. but during certain period of time, you're not having an effect.
Right.
And during
Right.
that time, you're the
I
envelope of
understand
your
what you're
oscillation.
saying.
Anyway,
Yeah.
we can talk about that offline someday. And
Right.
it's very, and you are right. The design of the device needs to, and the leads need to address that.
Yeah. Thank you. So Asif, are we out of time, or you or have some more, or what?
You can go ahead, please. We are okay.
Okay. If there's other questions, I'm happy to address them.
I don't see any hands raised, and let me see if anybody is asking any questions. There's nothing else in the chat. Oh, sorry.
I have a quick question.
Go ahead.
Great presentation.
Thank you. Joyce, is that right?
Yeah,
Thank
Joyce.
you.
Yeah. So it's interesting to see how you're looking at beta and gamma oscillations and in the adaptive Dbs. But do you think that's the whole story? Because in Parkinson's disease, there have been reports of like the features in the high frequency oscillations, theta band, and other frequencies. And also, why power? Because you could look at phase amplitude coupling or other ways of looking at it. And of course, my last point, which someone mentioned before, would be machine learning, because with the control, why can't we just simply adapt into machine learning and learn like when with the increases and decreases of? Right.
Yeah. Thank you, Joyce. So number one, your question is very apt. Even our initial publication on this focused a lot on beta and gamma frequencies, but in fact, if you look carefully, there are many other frequencies that can be used to predict motor state. And theta, I think you mentioned, is what I call the forgotten prokinetic frequency, because there's been some publications on it, but in fact, that is associated with the prokinetic state. The high frequency oscillations is a complicated story, the ones up at 200, 300 hertz. We've actually detected them with RC+S, but you have to set it at 1,000 hertz sampling rate, which is not very practical to do at home because there tend to be more so-called dropped packets of data, and that's a whole other technical thing. But we can detect those ultra high frequencies if we go to 1,000 hertz. The cross-frequency coupling story is interesting. We're very interested in that, but at this point, in an embedded device like RC+S, we don't really know a way to use these nonlinear types of control algorithms, and also it's very hard to calculate things like that quickly. So with RC+S, you can only use spectral power within a preset band as a control, and you can use multiple bands summed in some linear combination. You can also have multiple control policies, but it's all based on spectral bands. And your last point, I think, as we had mentioned before, I think it was maybe Bob who brought that up, doing this by hand, so to speak, is kind of absurd. And so, yeah, we're starting with one of my students, Lauren, or fellows, Lauren, is really starting to take machine learning approaches to this. And Simon Little, my colleague, with one of his students, is doing some similar things with trying to develop adaptive stim in sleep, to use machine learning to auto-categorize sleep state from these recordings and then make changes based on sleep state. So that's clearly where it goes.
Okay, thank you.
Thank you.
I don't see any more hands.
Okay.
Thank you so much. It was honor to have you here. And,
yeah, pleasure speaking with you.
And we'll figure out some time for you to be here in person, and we can show revived Cleveland downtown.
Yes, that would be really nice. Yeah, and I'm happy to correspond with people offline. And again, I welcome thoughts on this, things like the gamma entrainment and what that's doing. And it's really, again, a remarkably ubiquitous phenomenon now that we are able to look and we don't understand it. Okay, well, thank you guys so much. Pleasure talking to you.
Phil. Thanks for coming and joining us today.
Have a great afternoon.